Welcome to today's deep dive. Today we are tackling a highly specific, very heavily marketed question, and that is, can the O-shot actually improve sexual desire?
Yeah, it's a big question. And to get to the bottom of this, we're looking at a really fascinating stack of sources today.
Right, our mission is to cut through the heavy marketing of cosmetic gynecology and look at the actual clinical evidence. So we've got clinical practice guidelines from the Women's Health Clinic, a 2024 systematic review of clinical trials out of Oklahoma State University, prescribing tools from the British Menopause Society.
We also have an ethics briefing from the Nuffield Council on Bioethics and an incredible investigative piece from The Guardian.
Exactly. And, setting the stage here, if you are listening to this, you have likely seen targeted ads or magazine articles about this. It promised this really quick, injectable fix for low libido or sexual dissatisfaction.
Right, the marketing is incredibly slick.
Oh, absolutely. It presents this clean narrative, right? Like
Yeah.
you have low desire, so just get this quick localized upgrade and you're fixed. But today, we want to figure out if the science actually backs up that hype.
And spoiler alert, when we transition from that marketing copy into the actual neurobiology, the story gets a lot more complicated.
Yeah, I mean, before we could even judge if the O-shot works, we have to understand what it actually is, right?
Yeah.
Like, how does it biologically operate in the body?
Right, so the O-shot is actually just a brand name.
Oh, really?
Yeah, clinically speaking, it's platelet-rich plasma therapy, or PRP.
Okay, PRP. I feel like I've heard of that for, like, skincare and stuff.
Exactly, the vampire facial. It's the same fundamental idea. It involves taking the patient's own blood, running it through a centrifuge to isolate the platelets, and then injecting those concentrated platelets right into the vaginal wall and the clitoral body.
Ouch. That sounds intense.
It is a sensitive area for an injection, definitely, but the physiological goal here is that the platelets release growth factors, primarily things that stimulate neurogenesis, which is creating new nerves,
Right.
and angiogenesis, which is creating new blood vessels.
Okay, let's unpack this for a second. So it's basically like taking your body's own localized repair crew and, setting them to rebuild the plumbing and the wiring down there.
That is a great analogy. You're trying to force an increase in blood flow and nerve density.
Okay, but if it's this physiological repair process, are there rules patients have to follow? Like, does it just work automatically?
Well, this is where we hit a really fascinating clinical quirk. According to the guidelines, patients have to observe a strict NSAI ban. So no ibuprofen, no aspirin,
Wait, for how long?
usually 5 to 7 days before the procedure and 5 to 7 days after.
Wow, why?
Because the O-shot actually relies on inflammation to trigger those growth factors we just talked about. The micro-injury from the needle and the localized inflammation are what signal the tissue to regenerate.
Oh, I see. So if you take an anti-inflammatory, you're literally blocking the exact mechanism you just paid a premium to trigger.
Exactly. You'd be shutting down the very physiological response you want.
That's wild. Okay. So the biological theory of rebuilding tissue sounds promising on paper, but does the clinical evidence actually match those aggressive marketing claims about, supercharging sexual arousal?
Well, let's bring in that 2024 Oklahoma State University systematic review. They looked at the clinical trial databases specifically for PRP used for female sexual dysfunction.
Right. And what did they find?
So they found 18 clinical trials registered for this. But here is the kicker out of those 18. Only 3 actually published their results.
Whoa. Only 3.
Yeah.
So, I mean, that usually points to a severe publication bias, right? Like,
Yeah.
if a trial doesn't show a positive result, it just kind of quietly disappears.
Precisely. It happens a lot with experimental treatments. But when we look at the 3 trials that did publish, the distinction they make is really critical. They found that PLK is safe, and it actually works for treating physical dermatological conditions.
Like what kind of conditions?
Like the thinning skin or scarring associated with the lichen sclerosis. So it does help regenerate damaged tissue. However, and this is the key point, none of those studies found statistically significant improvements in sexual satisfaction, arousal, or desire.
None of them.
None of them.
Wow. And that lines up perfectly with that Guardian investigative piece we read. They quoted Professor Linda Cardozo, who stated flatly that there is simply no scientific data for procedures like the O-shot or G-spot amplification actually boosting orgasms.
Right. The structural repair happens, but it doesn't translate to psychological desire.
Here's where it gets really interesting to me, though. It's like buying a highly marketed sports car because the ad promises it can fly, but then you read the manufacturer's manual and it admits it's just a regular car.
Yeah.
Why is there such a massive disconnect between the marketing you see on Instagram and the actual clinical science.
That is where the Nuffield Council on Bioethics briefing comes in. They describe this whole sector of private cosmetic gynecology as a bit of a wild
A
west
Wild West, yeah.
because clinics will often blur the lines. They take a treatment that has some marginal evidence for a specific skin condition like tissue atrophy, and they pivot the marketing to sell it as a magical cure for a complex psychological and physiological issue.
Like low sexual desire.
Exactly. They bypass the strict medical assessments you're supposed to do and instead just sell a quick cosmetic fix.
So if the clinical evidence for the O-shot actually boosting desire is virtually non-existent, why is there such a massive lucrative market for it? People are paying thousands of dollars for this.
Yeah, out of pocket usually. To understand the demand, we really have to look at the orgasm gap that the Guardian piece highlighted.
Oh, the statistics on this were staggering.
Yeah, so according to their data, 95% of heterosexual men say they always climax during sex. But for heterosexual women, it's only 65%.
Though it is worth noting, the data jumps up to 86% for lesbians. But still, for straight women, that is a huge gap.
It is, and you have to couple that gap with this incredible historical ignorance about female anatomy. I mean, The Guardian noted that even recent medical textbooks have completely omitted the internal structure of the clitoris from pelvic diagrams.
Which is just crazy. If the medical establishment doesn't even map the anatomy properly, how is the general public supposed to understand it?
They don't. And that leads to things like chasing the mythical G-spot.
Right. I love this detail in the sources. Ernest Grafenberg, the guy that G-spot is named after, never actually claimed to have discovered a distinct anatomical structure.
No, he didn't. The term was coined decades later. There's no discrete histological entity there, but culturally, everyone expects it to be this magic button.
And think about that from the listener's perspective. If you are constantly told by society that you should be having these effortless multiple orgasms, and you don't even know the proper terminology for your own anatomy, you're going to feel broken.
Exactly.
It feels like this industry is just monetizing women's anatomical insecurities.
If we connect this to the bigger picture, it creates a perfect storm. Patients fail to, quote-unquote, find their G-spot. They feel abnormal, and so they pursue cosmetic gynecology as a quick fix.
Rather than addressing what's actually causing the distress.
Right. Which brings us to the actual physiological culprits that are killing desire.
Okay, yes. So if a listener is struggling with low desire, and an experimental O-shot isn't the magic bullet, what is actually happening physiologically? What should they be looking at?
The clinical guidelines break down the real medical culprits, and the first one is usually medications, specifically SSRI antidepressants.
Right, the guidelines call them sensation blockers.
Yeah. SSRIs raise your serotonin, which is great for stabilizing mood, but high serotonin actively blunts dopamine and norepinephrine, which are the neurotransmitters responsible for physical arousal and anticipating reward.
So your mood is stable, but your neurological pathways for desire are essentially muted.
Exactly. And the second major culprit is what the guidelines call the SHBG trap.
Oh, this was fascinating. This is related to the pill, right?
Yes, hormonal contraceptives. When you take synthetic estrogen orally, it has to pass through your liver, and your liver responds by pumping out sex hormone-binding globulin, or SHBG.
Which acts like a systemic sponge.
Perfect way to put it. It floats around in your bloodstream and binds to your free testosterone. And testosterone is a major driver of female libido, so the SHBG actively tanks your desire by locking up that testosterone.
Wow. So your hormones are basically trapped.
Yeah. And finally, the third big culprit is dyspareunia, or painful sex.
Which makes total sense. You can't have spontaneous desire if your brain is anticipating pain.
No, you can't. And the guidelines outline physical conditions that cause this, like hypertonicity, which is chronic pelvic muscle spasms, or cytolytic vaginosis, which is a bacterial imbalance that literally burns the tissue.
Wait, burning tissue. And people think an O-shot is going to fix that.
Exactly. When you have chronic pain from these conditions, you develop a fear avoidance cycle. The nervous system literally alters itself. It's called central sensitization.
The brain basically turns up the pain dial, right?
Yes, it starts interpreting normal touch as severe pain.
So what does this all mean? It means trying to fix low desire with a PRP injection while you're trapped by SHBG from the pill, or you're suffering from severe pelvic muscle spasms. It's like putting a fresh coat of expensive paint on a house with a crumbling foundation.
That is exactly it. which is why the clinical guidelines stress a biopsychosocial assessment first. You have to review the patient's medications, and you have to treat the pain through conservative therapies before ever picking up a needle.
Like pelvic physiotherapy.
Right, downtraining the pelvic floor muscles manually to reset that nervous system.
Okay, so let's say someone does all that. They fix their meds, they clear up the pain, but they still have this persistent low libido. What is the evidence-based route to restoring desire?
Medically, persistent low libido is known as hypoactive sexual desire disorder, or HSDD. And the true clinical gold standard for treating it is testosterone replacement therapy, or TRT.
TRT, okay, which people usually associate with men.
Culturally, sure, but women naturally produce testosterone and declining levels due to age, surgery, or the pills severely impact desire.
But the source has made it very clear that TRT requires intense monitoring.
Oh, incredibly intense. A 2024 clinical audit out of Leeds found alarming rates of poor compliance with blood test monitoring in primary care.
Because if it's not monitored, you get supraphysiological levels, right?
Dangerously high testosterone.
Yes. The female androgen receptors are very sensitive. If the dose is too high, you risk irreversible side effects. We're talking about vocal deepening, alopecia or hair loss, and clitoral enlargement. Which sounds terrifying if it's not managed right. So how do you actually take it? Is this just a pill you swallow every morning?
Well, this raises an important point. Oral estrogen and oral testosterone are strongly discouraged.
Oh, because of the liver thing we talked about.
Exactly. Passing through the liver triggers that SHBG spike. So instead, TRT for women is usually administered as an off-label gel or cream. Things like Tostarin or Andropheme.
Okay, so a cream.
Yeah, you rub a highly calibrated microdose into the lower abdomen or the thighs. But crucially, patients have to avoid skin contact with their partners or children until it dries completely.
Oh, wow. Because it could transfer to them.
Yes, secondary transference is a real risk.
Yeah.
And for the monitoring, it requires baseline blood tests before you even start, a mandatory 3-month review, and annual checks to ensure your levels stay strictly within the female physiological range.
It's definitely not a quick fix.
Not at all. It is a rigorous, ongoing medical commitment.
Wow. Okay, so to summarize this deep dive for you listening today, the O-Shot might be highly marketed, and it might sound incredibly convenient. But the clinical trials show no significant improvement for sexual arousal or satisfaction.
The data just isn't there for desire.
Right. So true solutions for low desire require looking at the underlying foundation. You need to look at your medications, the SHBG trap, pelvic pain, and potentially explore carefully monitored testosterone replacement therapy.
It's about addressing the whole system, not just the local hardware.
Exactly. Well, thank you so much for joining us on this deep dive. We hope this helped clear up some of the confusion around this topic.
I want to leave everyone with one final thought to mull over. Consider how our culture's obsession with finding a purely mechanistic, physical button to press for sexual desire, like injecting the vaginal wall, might actually be a reflection of a society that prioritizes a quick-fix performance over doing the really hard, complex work of understanding the emotional, psychological, and relational webs that truly fuel human intimacy.
That is a phenomenal point to end on. It's so much deeper than just biology. Thanks for listening, and we will catch you on the next deep dive.